Let's look at what we know about the epidemiology of measles and rubella in India. Why eradicate measles? I've already highlighted. This is with high morbidity, high mortality. It affects physical growth, negative nitrogen balance based. It affects cognitive development, something that is not understood by everybody. A lot of our children have not achieved their cognitive development potential because they got affected with measles at the wrong time. Causes blindness because of keratomalacia. It causes immune suppression, which is not also clearly understood by a lot of people. Of course, tuberculosis, pneumonias, dysenteries, diarrheas, quite well known following measles. But the immune suppression of measles can last more than 1 year. In Scandinavian countries, up to 2 years, children who had measles disease have more infectious diseases than others. Measles virus causes 3 kinds of encephalitis. What is post-infectious allergic encephalomyelitis, like in many other infectious diseases, and acute viral encephalitis, which is, of course, uncommon, and it occurs in immunosuppressed children only. The third variety of encephalitis is subacute sclerosing panencephalitis, SSPE. I will show you a little bit of data on that. And finally, it is eradicable because we have efficacious and safe vaccine. There's only one antigenic type globally. We have excellent diagnostic techniques, and there is no extra human source that fits in the eradicability of this agent. Just to remind you of the problems, a few of them. Slide borrowed from Sunil. Okay, the third kind of encephalitis I mentioned is subacute sclerosing panencephalitis, which was a neglected problem for a long time. In our region, catchment area shown in shaded graph, we had a lot of SSP that we had diagnosed. The male and female are shown here. The age range is from 2 years up to more than 20 years. The shaded ones are male, the others are female. The age at which measles had occurred in children who later on developed SSPE, less than 1 and 1 put together is the bulk of the, add 2 also. So less than 2 years of age at the time of getting measles is one risk factor for subsequent development of SSPE. What we found was 10 times higher incidence than reported in the West. The reason being increased proportion of the total population under 2, of course. So therefore, there will be more measles for populations. A higher proportion of measles cases in the very young, more frequent subclinical measles virus infection, and perhaps other host factors. Of course, SSV is like rabies. It's invariably fatal. What we have not been taught in medical schools is that there is a problem of low antibody response in infants with measles, and there is a problem of subclinical measles. Look at age distribution and mortality of measles in children under 5 years. Let me point out to you that death occurs essentially in children below 4, and cases minimal beyond age 4. Look at the case fatality rates. This, of course, are all pre-vaccine era epidemiology. Okay, after this, this is an epidemic profile. There are cases even in less than 11 months and some in 1 year, etc. 7 months after this outbreak, when we looked at antibody prevalence, children with measles, no surprise that they have antibody. But look at children who had no clinical measles. They are antibody positive because they had subclinical measles, 16 of 24. Moreover, the children who had antibody in the absence of clinical measles have very geometric mean titers or antibody levels. This is to project back into the risk factor of SSPE. Why do we explore epidemiology? The distribution and determinants of a disease will teach us the behavior of the agent. This is like spy work on the enemy during a wartime. We need to know exactly what the virus is capable of doing and is actually doing. The critical determinant, of course, the behavior of the virus, and the determinant, the most critical determinant is the magnitude, the numbers, sheer numbers, and the distribution of the susceptible population. The behavior of the virus is stable. It doesn't change. But the determinants do change. Lower birth rates and or increasing immunization will slow down the transmission, which would result in shifting of the age distribution to the right. I will illustrate that. Very high immunization coverage, leaving very small proportion of susceptibles at one point in time, can interrupt transmission. So, looking at epidemiology currently in real time will tell us if we are on the right track or not. That's why sensitive surveillance, laboratory-based, is extremely important for eradication or elimination. Eradication is global, elimination is regional, local. Eradication is elimination, global elimination is eradication. So that's the terminology that we use. Immunity profile, birth to 10 years in 1972, maternal antibody not 100%, it should have been 100%. So there is some waning of the antibody to undetectable level, rapid decline of the maternal antibody, and then before it reaches the bottom, infection already have started. And if you look at this is almost like a straight line of acquisition of infection and antibody response. The steep climb is from about 9 months and it reaches 100% by 10 years. Remember that. Median is about 2 years. Median meaning 50% of children had got infection and antibody prevalence. That's about that's an important number. So the distribution by age tells us that it's early start, median age at 2 years, saturation by 10 years, and all three shows very high contagiousness. The basic reproductive number, R0, if you do not know what it is, coffee break time or lunch break time, you ask me, I'll explain it to you, is 30 to 35. For comparison, even in the pandemic flu, the R0 was less than 2. So that's how contagious it is. Higher the R0, higher the coverage needed to interrupt transmission. cannot expect elimination without 95% or more coverage with MCV1 and MCV2, because it takes 2 doses to make sure that every vaccinated child is protected. If immunity gap is allowed to grow, virus will survive and then it will embarrass us later on. Measles used to occur in 1971 paper in well-nourished children. This is our campus school. I want to illustrate the fact that it's essentially a young child disease. Secondly, that the age is saturated by grade 5, that is 10-year-old children, no more measles. Everybody had been infected prior to that. Of course, no mortality in this area. Epidemiology and prevention of measles in rural South India that we had documented. This is village 1, in which a fairly large village with large number of children. Look at the attack rates and look at the case fatality rates in rural South India pre-vaccine era. Anywhere up to 20%. And if you take the entire under 10 children, case fatality rate of 14. There was a saying that don't count your children until measles has passed, because no guarantee that a child would survive 5 years if measles was not prevented. Okay, that is what I showed you in village number 1, the previous one. Village number 2, we had offered measles vaccine, and those who took, there was no case and of course no mortality. Those who did not take had cases. Small numbers, no mortality. Where healthcare was available, mortality was low or case fatality was low. In other words, a lot of case fatality associated with measles is not the measles virus actually killing, but a lot of secondary infections, undernutrition, kwashiorkor, etc. killing. So the 1972 graph showed us that the 9 months was the optimum age for measles, balancing between the best response and the highest need. This is 1972, and that was responsible partly for WHO accepting 9 months in 1974 when EPI was launched. There is some suggestive evidence, and just don't worry about it at this time, that the dose given at 9 months or younger than that, which does not induce the best antibody response, may adversely affect response to subsequent doses. This is a question that ICMR has been seized with in terms of investigating. So we will know the answers in a short period of time. So we looked at antibody response to measles at age range at fairly large number of children, 6 to 15 months. The seroconversion rate, 6 to 8, 9 to 11, and 12 to 15. If you want to get the best result out of the vaccine, you have to go to an age which is above 9 months, 9 to 11 months. But more striking than the antibody prevalence is the antibody titer. The antibody levels achieved at 12 to 15 months are much higher than antibody levels achieved at 9 months. Of course, obviously below 9 months too. So this may give an explanation as to why 9 months may not be the ideal for measles elimination in future, but of course that's a research topic that we will have answers when ICMR does its research. We have looked at MMR vaccine at 9, 12 and 15 months. This is published in IJMR, so don't have to spend much time. So if you give MMR vaccine instead of measles vaccine, 12 months is better than 9 months for both measles and mumps. But 9 months is okay for rubella vaccine. The priority for measles vaccine had been, when we have been advocating for it for a very long time. This is a 1983 paper. Remember, 1983 measles vaccine was not licensed in India. It was not part of India EPI. So all these are advocacy papers and studies and arguments in the medical literature saying that it is priority number one of all the vaccines that we use. Measles vaccine was the most important one. And I bring this paper in because the Rotary International had gifted 3.75 million doses of measles vaccine to the children of Tamil Nadu and Kerala. Although unlicensed, our then Chief Minister M.G. Ramchandran had got special permission from the Government of India for using it in Tamil Nadu. Kerala didn't get it, so therefore Kerala didn't take up this vaccine at that time. This is 1978 through 1983, and this experience was instrumental in measles vaccine being licensed and introduced into India EPI in 1985. 80 districts, concentrically expanded to all districts by 1990, when EPI was renamed as Universal Immunization Program. Just want to show you some a fascinating idea and experience and a study. Now, a village had outbreaks every alternate years and no measles in between. That tells you that measles overwinters, or somewhere it survives nearest city, nearest human conglomeration, where the measles virus can survive. But in a rural area where the number of children is small, away from the city, so measles appears as a periodic outbreak. So 3 consecutive outbreaks at 1 year gap, with 1 year gap. We investigated the third outbreak, in which 68 children had developed measles. Now the total under 10 population was 360. So 68 children had measles and the outbreak then stopped. It would take 2 years for that number to come back up to the number that would actually promote an outbreak. So just before a case was imported into that village, we, in the nick of time, we did a 1-day measles campaign, measles vaccine campaign, 1 year to 10 years. And we brought down that number very low. This imported case did not have a secondary case. That's the important thing. That if you reduce the number of susceptible children to very low, there will be no secondary case, or secondary case will be extremely low. 1 year later, we reduced the number of susceptibles further, because the newborn children are there, they become above 1 year, and the next year, and the next year. Each time vaccinating children who had missed vaccine previously. And we had documented importation of measles into the community, children going out and getting measles and coming back into the village. and no secondary spread. This is kind of a model which tells you the power of campaigns in reducing the proportion and magnitude of the susceptible population very rapidly, in which case the virus will not be able to survive. This Sunil have already shown MCV1 and MCV2, so I don't want to spend time on that. Even in 2014, India stands out as the one country, both in our region and globally, contributing to extremely high measles-related deaths. India had initiated outbreak-based and lab-supported measles and rubella surveillance way back in 2005, scaled up in a phased manner to cover the whole country by 2015. It's built on the AFP surveillance system with more than 40,000. I think it is 60,000 now. Sites across India for suspected measles cases based on a clustering of cases, 5 or more. It's called an outbreak, and then house-to-house investigations, virology, then identifying whether it is measles outbreak or rubella outbreak or mixed outbreak. Just to show you the results, this is also Sunil's slide. 2015, 1,115 outbreaks, 130 rubella. 1,115 measles, 130 rubella, and 44 mixed. Similarly, the next year, 780 measles, 261 rubella, 64 mixed. Now you can imagine why it is extremely opportunistic to club rubella vaccine with measles vaccine to eliminate 2 infections as rapidly as possible. The measles cases that were noted in 2015 and 16, look at the red part of the pie chart, unvaccinated. Some with 1 dose and a few with 2 doses. Remember, this is a demon lurking in the corner that might trip us up when you go for elimination. So we need to know whether the way we vaccinate with 2 doses would be sufficiently powerful enough to break the transmission. The age distribution of those investigated cases now 12% are now above 10 years. Previously, there was no case above 10 years. By 10, the children were saturated. Now, we have shifted the age a little broader because of immunization, and not yet sufficient to reduce the infection to very low levels. 16%, about 10 in 2016. This is another demon lurking in the corner that it might trip us up later on. Why? Because we target up to 15 years. Hopefully, there will be very few left above 15 years who are susceptible, but we already know that there are susceptible children above 15 as of now, and that is another researchable issue. We need to see what proportion of children are susceptible above 15. That also is something that ICMR is now beginning to work out as a research plan. Of course, rubella is well known to have a much broader age distribution because it's a much slower spreading virus than measles. It's not as contagious. Therefore, the inter-epidemic period of rubella that we have looked at is about 4 to 5 years instead of, for measles, every second year in the village. So a lot of adolescent and young women of childbearing age are rubella susceptible, and therefore we need to focus on that for rubella transmission interruption so that CRS will be eliminated. Rubella itself is a mild self-limiting viral illness for everybody other than the fetus. A lot has been mentioned about CRS, so I will not go into details. The importance for rubella as to why we are attempting to eliminate rubella transmission is because of CRS. Most of you are pediatricians, so I don't need to spend much time on CRS. Clinical diagnosis, if you have 2 items on group A, you have confirmed CRS. If you don't have 2 or only 1, then you go to group B, and if you have 1 of A and 1 of B, then you diagnose clinically CRS. This was a study, if I recall right, done by ICMR, and the grand total of that study was 190 children, and these 5 centers participated, and lab confirmed CRS was 35%, 65, clinically compatible, a few more, a lot of them 45% discarded. So this shows that CRS is real, it occurs here, it is underestimated because it is not counted, and if you want to count, pediatricians don't see these children very much, cardiologists will see, ophthalmologists will see, so we need to be very ingenious in developing a surveillance system for both measles and rubella plus congenital rubella syndrome, because this is not like surveillance for many other diseases. A lot of these children do not come to hospitals if they go brimada, so you don't take the children to the hospital. So we need to have a system that will capture cases in the community. Rubella is a very mild disease, therefore you may not be able to capture that in the clinics, and therefore CRS we have to have special ways of finding it. Elimination is precision public health. Surveillance must detect every case, endemic and imported. We must know how many cases actually happened last week and how many of the previous week had been virologically confirmed as to what is rubella, what is measles. So that is the kind of precision we need for surveillance, and all of you will have to chip in and help in sustaining when the surveillance system is established. Lab capacity has to be upscaled. Sunil already mentioned that. But more important from ICMR angle, quality reagents are necessary. And if we make our own quality reagents, we will save a lot of money. And quality assurance is extremely important, because if you misdiagnose, then you mess up the precision nature of public health. So innovative designs are necessary for both achieving high coverage and having clinical surveillance and laboratory surveillance. Thank you very much.